morning to all the delegates here. Hope you all had a pleasant travel, and thank you for your enthusiasm in participating in our Prostate Summit despite the testing weather. So an American writer, Alvin Toffler, said that illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn. So here we are at the Prostate Summit 2024 to unlearn and relearn many concepts in prostate surgeries. So on behalf of Team Senthil Multi Speciality Hospital, I welcome you all. So without much delay, we will move on to the academic session.
I would like to call upon Dr. Vikram to elaborate about the current role of Rezum in BPH. Sir has graduated MCH Urology from SRMC in 2008, consultant urologist and andrologist at Sri Paduka Speciality Hospital and Men's Health Clinic, Trichy. Sir has been an eminent speaker and operative faculty in several live operative workshops across the country. He is the founder member of Trichy Uro Education Foundation and chief instructor in a True Endourology Fellowship Program. Over to you, sir.
Very good morning to all. At the outset, I would like to thank Dr. Gauri Shankar and the organizing team for this opportunity to be here amongst you all. First of all, I would like to start with a disclaimer. Even in this era, in 2024, transurethral resection of prostate is considered to be the gold standard in prostate surgery. So what we are going to see today, especially for the and how does this work? So the concept is that we convert sterile water into water vapor at 103 degrees centigrade and inject it inside the prostatic adenoma. So it creates instantaneous irreversible cell death, and then slowly over the next 3 months the body resorbs the dead cells. So this is a small video clipping. Anyway, we will be seeing it live. As you can see, there are lateral lobes of adenoma here. This is around 50-60 grams prostate, a nice bulge. Definitely it's obstructing lateral lobes. Very ideal case to start Rezum with. This is the Rezum mission. If you can see, this is the needle. This white thing is the needle. We mark about 1 centimeter distal to the bladder neck. We go to the bladder neck and then come back 1 centimeter and then inject. Once I press a button, this white needle goes inside. And then 9 seconds it takes for the water vapor to go in. Those 9 seconds, we will start seeing blanching in these blood vessels. Now, in the next injection, you will be seeing that. See, already it has blanched. Then come back another 1 centimeter. What it creates is a 1 centimeter circumferential sphere of water vapor inside the adenoma, and then those cells dies, and then it gets resorbed. So here, as it is, you can see it has already started blanching. So right now, I am giving 2 shots in the right lateral lobe. You can see that blanching effect. It was all pinkish to start with. Now it has blanched. Now we are going to the left lateral lobe. The first injection is being given. Not much of bleeding will happen. Our vision will be reasonably good to have a good field of vision. So this is the first injection on the left side, and then now we are coming to the second injection on the left side. That's it. So each injection will take only 9 seconds, and then we have given 4. So less than a minute for the whole procedure, completely bloodless field. And then that's it. You can see everything is pale. It was all pinkish to start with. Now it has become pale. But what happens ultimately, the work will start happening only after a few weeks. Up to 3 months, slowly the resorption will happen, and then the adenoma shrinks, creating a way for the urine to come out. Now, what are the advantages? So far, this is the least invasive procedure of all in the minimally invasive surgical treatment for prostate, MIST. This is the least invasive. Very short learning curve. Most of the time our OT technician should be able to do this. Very short learning curve, something like ESWL. And it's a daycare procedure, can be done under local anesthesia. During the last Tapasukan at Curie Hospital, we did it under local anesthesia. It is suitable in high-risk patients. Those on anticoagulants, it's very useful. It's a very, very small portable machine and a reasonable track record. It was introduced in US, FDA approved for the last 7 years. So many lakhs of patients have undergone this procedure. So it has a very good track record. The best part here will be the ejaculation will be preserved. Maybe this is not an important point in elderly patients, but those young males with significant prostatic growth, adenoma growth, this is very valuable and very less complications. What are the disadvantages? It is expensive. The initial cost, it is definitely expensive. Probably, I would say this is the most expensive of all the procedures. This may not be curative. In long run, the adenoma can still regrow. So patient needs adequate counseling before they undergo this procedure. And long-term data, more than 10-year data or 20-year data is still awaited. Those all senior urologists would agree TURP is time-tested. We have been doing it for 30, 40 years. That sort of a long-term data is still awaited. But this is definitely a promising procedure considering that there is no challenger for TURP except the enucleations. And then this has come as a good challenger and it is very good procedure for medium-term results, with good medium-term results. Not very ideal for very large glands, like 200 grams, 300 grams. It's not very ideal because it will need lots of shots as well as it will take long time for the adenoma to resorb. So it may not be very ideal for very large glands. And it is again not ideal for those small 30 grams, 25 grams prostate where it is most of the time it is the bladder neck elevation causing outlet obstruction. So those patients are not ideal candidates for Rezum. Instead, they would do well with a bladder neck incision rather than putting a Rezum for them. So right now in my books, I keep them as these ideal cases. What are the ideal cases where I voluntarily offer Rezum as of now is elderly patients with or without comorbidities, where I don't see a potential threat of adenoma regrowth in the next 5 years, 10 years. So I don't have to really concern because they are that elderly. The first patient I offered Rezum was a 94-year-old gentleman who was on catheter for 1.5 years. He was not fit for any procedure. So all I had to do was Rezum. And any group patients with comorbidities. So the next subset of patients that we did was those with 2-3 stents inside for whom I can't stop clopidogrel aspirin for longer duration. Even if I started back, they have a threat of prostatic bleeds. So they are the second set of patients who can undergo Rezum comfortably. Third set is this patients working abroad. Those who don't have adequate time for follow-up, they'll come in a 10-day vacation and then they'll go back and then come back only after 2 years, for whom they are not responding to medicines. These are very ideal patients because they can continue their work from day one and then probably after a brief period of catheterization, they can be 100% normal. We don't have to worry about bladder neck contracture, stricture urethra, post-TURP bleeds. So all those complications, those long-term complications are taken care of. And then the next subset is those young patients, 50, 60 grams prostate at a 45-year-old age. So they are also ideal candidates to undergo Rezum. Another thing is when I never have the habit of combining multiple procedures, for example, bladder tumor with prostate, hernias, bilateral inguinal hernias with enlarged prostate, they are also ideal candidates because I am more worried about infection when I combine a hernia with TURP. I am more concerned about the infection, the mesh infection, bleeding. We have had a couple of incidences where post-TURP bleed and then interventions and all those things created a mesh infection and all those. So I prefer to avoid and counsel the patient against combining two procedures. But with Rezum, I am able to do it. So these are the ideal set of patients to start with. Whether it is median lobe, lateral lobes, that doesn't matter. Unlike when we compare with UroLift, where median lobe is not a very ideal candidate. In comparison to Rezum versus UroLift, the initial investment is very cheap or no initial cost of investment. Capital investment is not there in UroLift. But over a period of time, if you have done 50 cases, then definitely UroLift would be a more costlier procedure because it is simply like you will be earning money, give it to the Eurolift company. So that is how the Eurolift model works. But if it is a high volume center, you are able to have more number of such patients for Rezum, then Rezum would be a more cost effective procedure over a long time. Break even will be achieved within 45 to 50 cases, and then whatever after that, things are more comfortable, unlike Eurolift, where the initial expense is nil, but recurring expense is more. If the same prostate patient I have done a Eurolift, I would have spent nearly 2.5 lakhs just for the tacker, just for the clips. And Rezum, the patients will still respond to medical management after Rezum. The patients will not respond to medical management after Eurolift. And Rezum never excludes a patient from definitive procedures, especially those young males, or there are some patients who are ready to come back for a anatomical endoscopic enucleation of prostate after a few years. So those patients, Eurolift is going to be a challenge for us to re-intervene and go in that plane. But Rezum never does that. So we can even comfortably continue dutastride in those patients who want to avoid long-term regrowth chances, adenoma regrowth chances. The results are quite promising. I have done 11 cases so far. 3 monthly follow-up patients, my first set of patients have started coming for 3 monthly follow-up. Fantastic uroflow curves. All those who had residual urine, now it has all disappeared without medications. Patients are very happy. Thank you.